Greetings to my colleagues in Latin America from the Middle East region, from the Middle East Fertility Society, and from Lebanon in particular. My talk today is male subfertility, the conventional treatment versus FSH therapy. Male factor is the sole cause of infertility in approximately 30% of infertility couples and an additional 25% for causes of mixed factors. Many aspects of male factor infertility are poorly understood and not deeply investigated in the general practice. The high fertilization and pregnancy rates achieved with ICSI have led to the almost complete discontinuation of efforts to improve sperm parameters in vivo. The wisdom of abandoning such efforts should be questioned because the importance of good sperm quality for embryonic development is only now beginning to be appreciated. ICSI bypasses physiological selection processes, allowing sperm with severe structural abnormalities or increased aneuploidy rates to fertilize the oocytes. Moreover, an increased rate of de novo chromosomal abnormalities in the offspring of the patients was observed in several reports. It is essential that the justified enthusiasm surrounding the use of ICSI as the treatment of choice for male factor infertility should not prevent us from improving sperm quality and thereby achieving better results in both IVF and ICSI. The rationale for the treatment, whether we use medication or any other intervention, is to improve the semen quality and therefore to increase the pregnancy rates and outcome. The use of antioxidant is widely prescribed by specialists in reproductive andrology or in reproductive medicine, with the hypothesis that the reactive oxygen species that cause damage to the DNA, to the proteins and the lipids, affect negatively the fertility. So, checking the Cochrane library, we have found many studies that reviewed the use of antioxidant in male subfertility. And different antioxidants were used in the trials for a duration of 3, 6, and 9 months. Some studies, they looked at the total sperm motility. Others, they looked at the sperm concentration. And the comparison between a placebo or no treatment with the use of antioxidant, whether for patients going IVF or other procedures, have led to the conclusion that the evidence for live birth and pregnancy rates were found very low. These studies were highly heterogeneous, small-sized, poorly designed, and include multiple interventions. As you see here, IVF, natural conception, IUI, varicocelectomy, post-varicocelectomy. So there were many interventions used. So we found not in same interventions to make conclusions about whether one intervention is better than the other. Secondly, the use of androgens. The use of androgen as an empirical therapy is found also in the Cochrane library. However, going through literature from 1983 till 1995, we found not a single trial reported an improvement in pregnancy rate after the use of androgen therapy. Some studies were reported in other literature that were not included in the Cochrane review that we have seen. They have shown marginal improvement in sperm morphology. Others, they found no differences in the pregnancy rate. And some, according to WHO task force on the diagnosis and treatment of infertility, they found the use of androgen, oral androgen, unsatisfactory because of the low statistical power. The European Association of Urology guidelines on male infertility, published in 2012 update, they found that testosterone should be strictly contraindicated as a treatment option for men with idiopathic infertility. A recent survey of 387 urologists belonging to the American Urologic Association reported that 25% of the responders are still prescribing androgens for infertile patients in spite of no efficacy of the treatment and overuse of the procedure. Anti-estrogen. The hypothesis for the use of anti-estrogen is to take off the block of estrogen on the hypothalamic pituitary axis. That would release LH and FSH output and increase on the testis testosterone production and sperm output. So clomiphene citrate empiric medical therapy for idiopathic male infertility at a daily dose of 50 milligrams may increase spontaneous pregnancy rate. However, in the Cochrane library, clomiphene was used also in a dose of 25 milligrams. The clomiphene citrate treatment resulted in significant increase in sperm concentration and in percentage of sperm motility. Also, after clomiphene citrate, we found a significant elevation of serum FSH and serum testosterone. However, we found an imbalance between the study and control arms, and we found small observations like an improvement of 10% of pregnancy rate over 6 to 12 months of clomiphene citrate therapy. So the WHO double-blind multicentric randomized 190 couples and that was published in the journal, Internal Journal of Andrology in 1992. Using clomiphene citrate 25 milligram for 6 months. No significant differences. Other study in 1984. No significant differences. Other studies using tamoxifen, unable to establish the real efficiency of the treatment. And finally, the latest studies in the European Journal of Urology in 1990 using tamoxifen, small improvement on concentration, no effect on motility and morphology. So anti-estrogen therapy, most common treatment utilized due to its lower cost and easy administration. When it comes to the results, only a small group of this entire population seems to respond to the treatment. All randomized studies failed to demonstrate an improvement in the pregnancy rate. For the aromatase inhibitor use, reviewing the literature again, we found no consistent changes and none of the wives became pregnant. What about the gonadotropin therapy? What is the hypothesis? Well, using the gonadotropin medication or therapy, HMG, FSH, LH, or HCG, with the rationale that this gonadotropin will stimulate the Leydig cell and will stimulate the testis in general to improve spermatogenesis and to increase the output or the secretion of testosterone. The gonadotropin releasing hormone therapy in cases of hypogonadism, hypogonadotropism, it helps for the recovery phase that goes through several stages. Functional recovery of Leydig cell, improved function of seminal vesicles and the prostate as well, recovery of epididymal function, perhaps subsequent to tubular function improvement, recovery of Sertoli cell function, which even in this population is more difficult. For the use of HCG, human chorionic gonadotropin, HCG has been commonly used for many years, leading to stimulation of the Leydig cell and increase in testosterone production. The lack of stimulation of the Sertoli germ cell compartment is observed and studied. LH is triggering the synthesis of IGF-1 by Leydig cell and their IGF-1 receptors. The IGF-1 is an important regulator of steroidogenesis and spermatogenesis. Going through the Cochrane library, we found in all the studies a beneficial effect on live birth and pregnancy of gonadotropin treatment for men with idiopathic male factor subfertility. However, because the numbers of trials and participants are small, the evidence is insufficient to allow final conclusion. However, in all these studies, we have found an additional 10% pregnancy rate over 6 to 12 months of treatment with significant direct and indirect cause. And finally, FSH therapy. FSH, it's inadequate endocrine stimulation to the Sertoli cell. It enhanced FSH-dependent functions, including spermatogenesis in abnormal gonadotropin secretion in pattern or quality, especially the cases with partial Sertoli cell deficiency. Production of cyclic AMP, androgen binding proteins, inhibin, ceruloplasmin transferrin, and plasminogen activator. So FSH is responsible for the quality of the spermatozoa in general and for the sperm-zona pellucida interaction in particular, accounting for the improvement in the fertilization rate. FSH therapy may positively influence testicular function by improving sperm parameters and sperm ultrastructure. And this was documented in all the studies with the use of electron microscopy. The increase in fertilization rates after FSH therapy may be related to improvement in subcellular components of the sperm. And this treatment could restore defective spermatozoal maturation, mainly of the acrosomal and nuclear regions. So long-term exposure in vivo to exogenous FSH of normogonadotropic, normogonadal man with OTA and proven low fertilization potential resulted in fourfold increase in their sperm fertilization potential. And we here find in this slide, in a study done by Ben Raphael, that the use of 75 international unit daily or the double dose daily versus the control found that the fertilization of oocytes almost doubled. And the fertilization rate, it went almost fourfold, 3 to 4-fold. The pregnancy rate per cycle in the first group was 1, and in the second group that received 150 units was 2. And look in this slide, the subcellular organelles before and after the treatment, particularly the acrosome, the nucleus, and the axoneme. This is important. That will be reflected on the sperm quality and embryonic quality and implantation rate. After FSH therapy, inhibin B increases and it plateau at the second week and will continue so for another 12 weeks. The same for FSH. Ashkenazi, using purified FSH, found that the mean number of embryo transferred after the therapy was 3.1. The grade A embryos was doubled from the control, and the clinical pregnancy rate was also doubled. The same applies for the implantation rate. So 70% to 75% of OTA normogonadotropic subjects treated with FSH for 6 months showed a bilateral significant increase in intratesticular blood flow, a decrease of resistant indices, an increase of flow capacity of the same vessels, an enhancement of oxygen supply, and consequently reduction of germ cells exposure to reactive oxygen species that is responsible for DNA breakage and lipid peroxidation. So Dernfeld even studied a group of patients receiving the FSH therapy She found, or she reported in the European Journal of Obstetrics and Gynecology, a fourfold report in pregnancy rate in the spontaneous pregnancy rate, as per 28%. Summary: FSH therapy promotes the expression of FSH receptor on Sertoli and germ cell surface. The post-receptor response is increased. Spermatogenesis improved. Inhibin secretion, inhibin B secretion increased. Pre-treatment inhibin B levels are a result of the functional status of hypothalamic pituitary testicular axis. FSH may be a valuable pre-treatment for oligospermic patients undergoing ICSI by improving sperm parameters, sperm structure, and fertilization rate. The improvement of inhibin B levels after the therapy is the result of gonadotropin FSH action on testicular paracrine activity. And thank you very much.